Bronchoscopy involves inspection of the interior of the tracheobronchial tree through an instrument called a bronchoscope, endoscope. The two types of bronchoscopy include flexible fiber optic bronchoscopy and rigid bronchoscopy. Surgical bronchoscopy always includes diagnostic bronchoscopy when performed by the same physician. The scope can be inserted through the nose, mouth, endotracheal tube, or tracheostomy site. Bronchoscopy, rigid or flexible, including fluoroscopic guidance, when performed, diagnostic, with cell washing, when performed. The airway is anesthetized. The physician inserts the bronchoscope through the upper airways, noting any abnormalities. The vocal cords are visualized and the structure and function are noted. The bronchoscope is advanced into the tracheobronchial tree. All of the airways are inspected. It may also include the obtaining of diagnostic specimens as part of the examination. This may be done with or without fluoroscopic guidance. After diagnostic visualization of the bronchus, cell washings may be obtained through the bronchoscope. If the physician is only looking at the endotracheal position, ETT, without advancing the scope far enough to assess the bronchus or bronchioles without anesthesia, then would it be appropriate to report code 31622 appended by modifier 52, reduced service? From a CPT coding perspective and based upon this proposed scenario, if the patient was already intubated and the physician is only passing the scope through the lumen to ascertain ETT position, then it would be appropriate to report code 31622 appended by modifier 52. Bronchoscopy, rigid or flexible, including fluoroscopic guidance, when performed, with brushing or protected brushings. Sample lung tissue is obtained with brushings or protected brushing through the scope. The brushing is performed over visualized abnormal mucosa, possible tumor, or the brushing may be performed peripherally into the area with an infiltrate. Brushings or protected brushings take significantly more time to perform than bronchoscopy with cell washing. Protected brushings involve passing a catheter through the bronchoscope into an area of the diseased lung, often with the use of fluoroscopic guidance, not reported separately. The catheter seal is broken and an uncontaminated brush is then advanced beyond the catheter to obtain specimens for culture and sensitivity, or an unprotected brush is used to take samples for cytology and microscopic examinations. Several passes of the unprotected brush may be required and are included in the overall procedure. Bronchoscopy, rigid or flexible, including fluoroscopic guidance, when performed, with bronchial alveolar lavage. The bronchoscopy includes bronchial alveolar lavage, which allows lung tissue to be sampled by irrigating with saline followed by suctioning the fluid. The bronchoscope is removed. Bronchoscopy with alveolar lavage, which is not the same as routine washings. Bronchial alveolar lavage, BAL, allows the recovery of cells as well as noncellular components from the epithelial surface of the lower respiratory tract. This differs significantly from washings, which refer only to the aspiration of secretions or small amounts of instilled saline from larger airways. Bronchial alveolar lavage involves repeated installations of sterile saline occurring in aliquots with aspiration into one or more containers. Large amounts of saline are pushed into the airway and then recovered by suction. Bronchoscopy, rigid or flexible, including fluoroscopic guidance, when performed, with bronchial or endobronchial biopsy, single or multiple sites. The physician views the airway using a flexible fiber optic or rigid bronchoscope that is introduced through the nasal or oral cavity. The airway is anesthetized. The bronchoscope is inserted and advanced through the nasal or oral cavity, past the larynx to inspect the bronchus, including fluoroscopic guidance, if used. After diagnostic visualization of the bronchus, a sample of bronchial or endobronchial tissue is removed for study. More than one site may be biopsied. It is important to note that code 31625 should be reported only once, even if performed at different anatomic sites. How many times should code 31625 be reported when a bronchoscopy is performed with endobronchial biopsies of 3 sites? Code 31625, bronchoscopy, rigid or flexible, with or without fluoroscopic guidance, with bronchial or endobronchial biopsy, single or multiple sites, should be reported only once for a bronchoscopy with endobronchial biopsies of 3 sites. This code is intended to be reported once, regardless of whether one or more biopsies are performed on a single site or multiple site. If a physician performs a tissue biopsy in a trans-bronchial needle aspiration biopsy, Wang needle biopsy, during bronchoscopy, can he or she report CPT codes 31625 and 31629? Since these are distinct procedures, it would be appropriate to report them separately with codes 31625, bronchoscopy, rigid or flexible, with biopsy, and 31629, bronchoscopy, rigid or flexible, with trans-bronchial needle aspiration biopsy. Bronchoscopy, rigid or flexible, including fluoroscopic guidance, when performed, with placement of fiducial markers, single or multiple. The bronchial biopsy is performed with biopsy forceps directed at visible bronchial tissue or a visible endobronchial lesion. After inspection of the upper airway and vocal cords, and usually after placement of an endotracheal tube, all of the airways are inspected and the site or sites for the bronchial biopsies are determined. The biopsy forceps is advanced through the suction channel of the bronchoscope into the airways. Bronchial biopsies are obtained from one or more sites and placed in formalin and sent to pathology. The bronchoscope is then withdrawn from the airways and removed from the patient. Bronchoscopy, rigid or flexible, including fluoroscopic guidance, when performed, with trans-bronchial lung biopsy, single lobe, 31628 should be reported only once regardless of how many trans-bronchial lung biopsies are performed in a lobe. Biopsies taken peripherally with fluoroscopic guidance of the biopsy forceps. It is performed by inserting a biopsy catheter into the periphery of the lung, using fluoroscopic guidance, and taking a lung biopsy. A fiber optic bronchoscope is inserted through the nose or mouth, visualizing the upper airways to the vocal cords. The vocal cords are visualized and observed for function. An endotracheal tube is usually placed. The bronchoscope is advanced into the trachea. All of the airways are inspected. Forceps are advanced through the suction channel of the bronchoscope into the right lower lobe bronchus leading to the infiltrate. A fluoroscope is activated and the biopsy forceps are advanced into the infiltrate, then backed off by 1 cm to 2 cm. Under fluoroscopic guidance the forceps are opened, a trans-bronchial biopsy is obtained on expiration, and the forceps are removed. The bronchoscope is withdrawn from the airways and removed from the patient. Inspection of the chest for a pneumothorax is performed with the fluoroscope. The biopsies are placed in formalin and/or saline and sent to the laboratory. In 31628 and 31629, the physician uses the views obtained through the bronchoscope to identify abnormal structures in the lung to be biopsied. Fluoroscopy may be used to assist with navigation of the bronchoscope tip to the abnormal tissue. In 31628, the physician passes closed biopsy forceps through a channel in the bronchoscope and through the bronchial wall to obtain one or more lung tissue samples from a single lobe. Bronchoscopy, rigid or flexible, including fluoroscopic guidance, when performed, with trans-bronchial needle aspiration biopsy, trachea, mainstem, and/or lobar bronchus, I. 31629 should be reported only once for upper airway biopsies regardless of how many trans-bronchial needle aspiration biopsies are performed in the upper airway or in a lobe. A needle is passed through a channel in the bronchoscope and through the bronchial wall to obtain one or more aspiration biopsies of the trachea, mainstem, and/or lobar bronchi. Bleeding is assessed and controlled, and the bronchoscope is removed. Trans-bronchial needle aspiration biopsies, which are taken centrally by penetration of a large airway with a specially designed biopsy needle, Wang, and aspiration of a lymph node or central mass lesion. The biopsy is performed by piercing the bronchus with a Wang needle and sampling a mass or a lymph node directly. A fiber optic bronchoscope is inserted through the nostril or mouth, visualizing the upper airways to the vocal cords. The vocal cords are visualized and observed for function. An endotracheal tube is usually placed. The bronchoscope is advanced into the trachea. All of the airways are inspected. A trans-bronchial biopsy needle is passed through the bronchoscope into the trachea above the carina, where the bronchoscope has been positioned. The needle is positioned and the bronchoscope and needle are inserted through the mucosa into the subcarinal area. Manual suction is applied through a syringe to aspirate the biopsy into the needle, and the trans-bronchial biopsy needle is removed and the specimen is delivered into an alcohol solution. Usually several biopsies are obtained at the one site, and the bronchoscope is removed carefully from the patient. Bronchoscopy, rigid or flexible, including fluoroscopic guidance, when performed, with tracheal/bronchial dilation or closed reduction of fracture. The physician performs tracheal/bronchial dilation or closed fracture reduction using a flexible fiber optic or rigid bronchoscope introduced through the nasal or oral cavity. The physician uses the views obtained through the bronchoscope to identify any narrowing or fracture of the trachea or bronchus. The physician introduces a wire through the narrowed or fractured part of the airway and removes the bronchoscope. A series of dilators or stents are passed over the wire to open the airway until sufficient dilation or closed reduction of the stricture or fracture is accomplished. This may be done with or without fluoroscopic guidance. A rigid or flexible bronchoscope is advanced to the stenotic area. A dilation catheter is placed through the bronchoscope into the opening of the focal stenosis and under fluoroscopy is threaded distally to just beyond the focal stenosis.